Not only that, if we extrapolate this, the temperature is expected to rise by 4 degrees centigrade by 2100, and which could lead to 40% loss of the terrestrial life forms and increase water scarcity and change in the weather, which we are already observing. So why this is important to us? This is basically the big, as by the WHO, World Health Organization, this is the single biggest health threat facing the humanity. And not only that, it will threaten the clean air, safe drinking water, and could reverse decade of progress in global health and development. So as we have seen that in the past 40 years have been seen unprecedented warming, with the last 7 years have been the hottest on the record. Human activities are driving climate change, which are leading to more frequent extreme of weathers, heat waves, floods, and food supply disruptions. And because of that, there is increase in vector-borne disease as well. So almost all the sectors are involving in the production and contributing their effect in giving a rise in the greenhouse gases. And as a healthcare, we are also contributing it as only the US is around contributing 8% in the national greenhouse gases. The acute care setting is the second most carbon intensive care setting following the food service industry, whereas operating room alone consumes 3 to 6 times more energy than hospital as a whole. So if you look at the global surgical market, it was around 3 trillion in 2023 and is expected to rise by $6 trillion by the end of 2033. So what is the impact? Impact is the healthcare industry accounts for 4.4% of global net emission, which is equivalent to 2 gigatons of carbon dioxide annually. And if we compare, it's equivalent to burning of 514 coal-fired power plants. And if we take it as a country, it is the 5th larger emitter in the world. Not only that, performance of 4,000 surgeries per 100,000 individuals, it also increases the risk to the healthcare individuals, exposing anesthesiologists, dentists, nurses, and OR staff. Now, what is the impact on overall impact? The overall impact is basically healthcare system is developing. We are treating people, but at the same time, this carbon dioxide emission and this greenhouse gas effect is basically leading to almost 4 lakh additional disability, adjusted livelihood disruption annually. Because of that, we have early loss of either disability or loss of life annually, or around 4 lakh people. So in simple perspective, if we are giving anesthesia with a fresh gas flow around 0.5 to 2 liters, it is equivalent to driving a car with desflurane is around 400 miles, with isoflurane 40 miles, and with sevoflurane 18 miles. So the initial focus, and we are working on it, we are continuously working on it, but initially the focus was more on to look at how we can deal with solid waste recycling and how to reduce the carbon emission. But now people are more focusing on emission with manufacturing affecting air, water, and soil, because directly or indirectly with the production of different devices, this will affect the natural resources. Holistic and environment preferable choices and promote efficient use of natural resources toward a circular economy, which I'm going to talk about later. So we as an anesthetist can play a key role in giving sustainable anesthesia and improve the healthcare system. So what are the strategies? Strategies basically are two. One is to minimize exposure and waste of anesthetic gases, and to look at the life cycle assessment and to see for that usable and reusable items. So first is the strategies to minimize anesthetic gases. For that, we need to understand what is global warming potential. It compares the effect of a gas to that of carbon dioxide and measures how much heat 1 ton of gas can produce in the atmosphere over a period of time. So it look at two things, the atmospheric lifetime and the amount of heat it absorbed. So if, for example, an anesthetic gas has a high global warming potential, which represents around 2500, or have a higher lifetime, that is, that is 110 years in the atmosphere, this can potentially adverse the climate. So for that, we try to search for different strategies, and we just published an article a few months back in which we look at the different strategies and reviewed over more than 40 articles to see what can be done to improve on that. So we have learned anesthesia on this machine. Most of has seen this machine. This is also already present in our operating room as well. And with this machine, technically, it was impossible to give highly efficient, low-cost anesthesia. So now with the technological advancement and with the digital flow meters, it is possible to give low-flow anesthesia, which helps reduce gas consumption, conserves resources, minimize emissions. But this requires careful monitoring to ensure safety and comfort. Now, with further advancement, there is machines which are available with automated low-flow anesthesia, with the closed circuit system and the proprietary software algorithm, which further cut down these consumptions. There are different companies which are offering this automated low flow. And basically, it has shown that if we use low flow and then we have incorporated some kind of automated flow system, then we can reduce the exposure of gases by 40 to 55%. Obviously, we need more advanced vaporizer for that. We cannot use dial flow meters. We need to control the end-tidal oxygen concentration. We need to control end-tidal anesthesia, and we need to give gases in a way which are more efficient, and we have to control that. For that, we need specialized vaporizers. Now, having advanced machine, having advanced vaporizers, we need to have some kind of monitoring by which we can see how we are doing and how we are performing and how we can improve on ourselves. So for that, different companies are now offering a cloud-based data system, one of which this Care Station Insight, which not only helps us to monitor the flow that we are giving in the operating room or as a whole in the suite, but also helps to look at the number of cases we are doing, carbon dioxide that is being given after the use of this OR, and then the cost. So we can monitor overall situation, not only for the operating room for that particular day, but we can look at the trends over a period of time of different OR as well, so that we can improve on our practices. Along with that, we can also look at the efficiency of first case start time, turnover time, utilization, and the flows that we are using at induction, maintenance, and emergence. Then obviously, when we are using gas, it has to go somewhere. So for that, we need to have an advanced scavenging system in place so that the exposure to the healthcare system is minimal. Now, with this advancement in the technology and with this sophisticated equipment, we need to have a strong biomedical team and through which we communicate, and to have a regular maintenance of these machines to make sure there are regular checks, calibrations, and proper functioning of the advanced scavenging system. Apart from that, we need comprehensive training and education, and then we need protocols to make sure that everything is aligned properly. So for overall processes, from buying equipment, then putting it in a way that we have a proper training system, we have a strong biomedical team, we need to understand that we need to have anesthesia support at backhand. Without that, it's not because it's not only labor intensive, require training and understanding, but also require resources and finances as well. And to make institution understand that we need this thing to improve on our practices, we need to research and we need to investigate and see what kind of things we are required to improve on our services. So we need to do research, and basically the goal is to enhance the understanding of sustainable anesthesia practices and develop evidence-based approaches for the improvement. So it's not just a single entity that putting in an advanced machine in the OR will help reduce the flows, but you have to phase-wise make an understanding how to improve on overall system. So if you talk about the ideal anesthesia, it's not just a clinical indication. It basically, we have to look at the occupational risk as well as on the environmental impact. So in conclusion, the strategies outlined represent essential steps toward enhancing safety and sustainability in anesthesia practices. Anesthesia should play a key role to make the institution understand, to make a bigger system understand that we need to have a system not to reduce the usage of these anesthesia gases, but also to make sure that we have proper training and education as a whole in our setup. Now, the second component of my presentation is based on the life cycle assessment. So basically, it's not about using a disposable item or reusable item and which is good or which is bad. It is basically to look at the life cycle assessment, which is a scientific method for analyzing the cradle to grave environmental footprint associated with natural resources, extraction, manufacturing, packaging, transport, use or reuse, and recycle or waste disposal of the product. So we are only sometimes look at the single phase के usable अच्छा है या disposable जो है वो अगर हम use करेंगे तो उसकी cost और उसका जो benefit है मिल रहा है कि नहीं मिल रहा. But again, the important thing is that how we are getting the material, how it is manufacturing, how it is reaching to us, and then how it is going to be disposed of. This is very important. But now people are thinking about putting in few important points in it. And one is basically the waste during manufacturing. Then before disposing it off, look at whether it can be reused, or when we are disposing, we have to see if it can be reused to manufacture the same thing. That is very important. So this, from there comes the term circular economy. To look at the way to use the item, whether it is reusable or usable, when we are disposing of in a way that it's environmental friendly. So in this prospect, different articles have been published, and they have looked at it whether reusable items are better in terms of reducing the carbon footprint or disposable items. So technically comes to mind that if you use reusable, then it will be better for the environment, and if you use disposable, it will give more waste. But there are controversies in the literature, and few of the articles have suggested that with the reusable, cleaning it, dismantling it, and then packing it, it will be more harmful to the environment as compared to the reusable. So there are mixed opinion in the literature, and nobody can advocate about whether to use go for the disposables or for the reusables. So there is a way where we can which we can improve our practices, but we need to remember the 6 R of the waste management to decrease environmental impact and the cost as well. The first is to refuse. So minimize waste by saying no to unnecessary equipment, test, and resources. That is the key. Decrease waste and energy usage by preparing only necessary supplies. Choose reusable equipment like laryngoscope blades and washable heads whenever possible. Separate recyclable sets, set up recycling programs for material like plastic wraps. Do research and look our practices. And always consider rethinking and look for the alternates to make sure that our practices are improving over a period of time. So in summary, basically, if we look at the overall picture that I've given to you, is basically the key is to minimize the anesthetic gas exposure, integration of advanced technology to enhance efficiency and reduce waste, emphasizing on ongoing education and training in sustainability practices, fostering a culture of responsibility that prioritizes environmental stewardship, reprocessing reusable anesthetic equipment to help cause. But as I said, they may have an impact on the environment or not, they may have impact on the cost. And call for the action for the anesthesiologists. Anesthesiologists can play a key role, especially in the operating, to make sure that the equipment that we are using, the gases we are using to make protocols and to do research and to investigate and see how we can improve on ourselves. Thank you very much.
Thank you very much, Dr. Khalid Samad. Any question from the audience? It was really a very wonderful talk and need of the hour, because we need to minimize the exposure to anesthetic acid and reduce waste. So any question from the audience, please?
Dr. Samad, what is your take about regional anesthesia?
So we are doing it. Actually, we are more advocating it, that we should go for either total intravenous anesthesia or for the regional anesthesia, in which we can minimize our usage of the anesthesia machine and anesthetic gases. So obviously, if we are not using circuits, we are not using disposables, and we are just doing surgery in the blocks or regional anesthesia or TIVA, it will certainly improve on this, reducing the carbon footprints.
Any other question, please?
I mean, as they say, it depends on how you're measuring, because anything and everything that humans do comes at a cost, in terms of energy. And we know that fossil fuels are actually the backbone of energy. Even if we start pretending that it's going to go away, it's not, they're not going away. So would it not be a good idea to go back to Stone Age and live like the way I mean, that would be maximum kind of.
That is why I've shown you my anesthesia machine that we use to we train ourselves on in the initial slides. They have less moving parts. There is less cost to the manufacturing. And someone has advocated in the literature as well that as we are advancing more in the technology, it is costing more, as well as is the energy, require more energy production. It require more energy, and this will lead to more carbon footprint.
Yeah.
So basically, you are right.
Yeah.
Technically, you are right. Yes.
Interestingly, because apparently when we are using a computer and we're using artificial intelligence, we think it's coming for free at no cost to the environment. Actually, the cost of producing artificial intelligence in terms of minerals and everything, it's phenomenal.
Actually, this is the other side of the picture. Yes, definitely.
So if we have no any more questions, can we proceed to the next presentation, please?
Thank you, Dr. Khalid. Your talk offers valuable guidance for minimizing our ecological footprint. Next up, we have Dr. Asma Akram, a fresh but valuable addition to our department with a specialized interest in pediatric anesthesia. We're glad to have her on the team and look forward to her insights on provision of stress and pain-free healthcare today.
Assalamu alaikum, everyone. Thank you, Sana, for introducing me. I'm Asma Akram. I won't take much of your, after all that intellectual talks. My topic is very simple, but very relevant to what we do every day. So this is a marketing quote, actually, that the customer should be king. And they always debate that whether they should be king or they should not be king. But my point is that they should be king. And the kind of king we are dealing with is this. So, So they should, so Sana said, my interest is pediatric anesthetist. So my talk is more to the pediatric anesthesia. So what we think is that the children who are coming for a healthcare, and especially working at Shaukat Khanum and in other parts of the country, we are dealing with the small people who are stressed and who require our attention. So they should be treated gently. Okay. So this is what we want, but this is what we see. So you all have come across crying, agitated, anxious, clinged to their parents, and hysterically crying, actually, not listening to you what you want to say. Okay, so what I'm gonna go through is how you can deal with it. So you see here, it is, you can say that it's exaggerated, but it is through this multiple systemic analysis that preoperative anxiety in pediatric population is up to 75%. There is a good resource here. This is a very recent. It's actually from 2020, and it looked at like 309 studies and a patient number of 3,000 plus. And they found out that it is quite prevalent in the population all over, not in Pakistan, like it's all over the world. Okay. So what is anxiety actually? It is when you can't comprehend the situation where you are, when you can't listen to the people, when you're just thinking what's happening to me, and it manifests as crying, anger, behavioral unrest, and in extreme situation, they might urinate there or display hypertonic behavior. You'll be like, oh, and they will eventually try to escape the room. And this has happened to me a lot. So this is what which you see, and this is what which is it's actually creating an impact on your things. So on anesthesia, you need more anesthetic doses. There's a prolonged induction time. We all have struggled, like just to calm down a child, just to introduce a mask, you take like 5-10 minutes, and surgeon is like looking at you. And then after that, if you pre-medicate them, there's a prolonged recovery time. They can be delirious in recovery, prolonged PECU time. They can feel more pain. They will be discharged, delayed, and then it increase the surgical morbidity. I think surgeons won't agree with me, but I have it here. So any kind of stress or anxiety can increase the glucocorticoid secretions in your system, which leads to increased infection, increased wound delay healing, and then the delay recovery. So it puts a cost on your hospital system as well. This is what everybody has seen, I can say. So the child is being physically strained. So holding children down for procedures, it is an international survey. It took the it took the input from the US, from Great Britain, from Ireland, and it says that nurses said that as much as 48% of the nurses reported that the children had to be held down for the procedure, and it's quite alarming. I have one more here. This is from US, and it says. Well, their data is not very bad. It's actually 0.8%, but this is the hospitalized patients only. Okay, so there's emergency department and there's a theater as well. Okay, so next we come to one of the studies from Pakistan. And this was after introducing some distraction techniques and things like that, but they still had to restrain 20% of their patients. That's quite a lot. Okay. So what do the children feel when you restrain them? It hurts. It hurts very badly, actually. So they say, I feel like I was suffocated. They feel like I was very stupid and everybody else was very intelligent and they were trying to be very nasty with me. They felt like they were the king, but actually he should be the king of the room. And this all leads to a physical and psychological state and powerlessness. Lose the faith in healthcare system. It's very difficult to bring them in again. Okay, so we really need to work on it. Distress during the induction of anesthesia. One of the studies from anesthesia and analgesia, it says this is more about like what happens afterwards. Like this is what we talked is what is happening there and then. This is what's happening afterwards. Like extreme anxiety during the induction of anesthesia can lead to the post-operative negative behavioral changes. And there are loads of studies on that. Okay. And it is proven that it can not only cause the delirium in the PACU, but you are leaving a long lasting impact. Okay. You can have agitation, delusion, nightmares, fear. You would have the parents, if you just ask them, they will be like disturbed sleep and psychological disorders. One of the studies which I'm going to mention here, it's actually not there. They say that most of the patients who are coming with the distress or depressed when they're young, when they're young adults, they would have such a scenario when they were very small. So they carry it a long way. So this is our systemic analysis, and now we are going to look into the patient factors, environmental factors, and how we can when you know the cause only, then you can prevent it or have an intervention on. So this is, they have 3,000 plus patients, and they identified 16 important factors for preoperative anxiety, but they said the 5 were the more relevant, in which they said the younger age, that it causes the patients of the younger age group they are more at risk of developing preoperative anxiety. Parental anxiety itself, like the parents, if they are anxious, they are transmitting that to their children. The negative previous hospitalization, and if the children is less sociable, not talking to you. And then the surgical setting, some surgeries like eye surgery has been proven to be that. And the repetitive procedures, like patients who are coming to us in oncology settings, they are coming repeatedly to us. So these kind of the things which can put them on hot seat. Further are the developmental delay, separation anxiety, which we'll talk about more in detail afterwards. So it is more common in 7 to 8 months. It peaks at 1 year. And in the elder, in the little bit more when you go further. So when you are 3 to 6 or more than that, there is more fear. They are understanding. Okay, they are not foolish. They are understanding. They need a description from you. And then the child with the psychological problems and the temperament of the child. So it is very important. We are very temperamental here. So if you see this is mapping positive and negative emotions according to the intensity. And if say the child who are angry, anxious, and scared, and then the child who are sad, bored, and tired, they both are equally prone to get social anxiety, not even the preoperative anxiety. These are the few things, like if they're less active, if they're more shy, or if they are very hyper, they are the kids which can have the preoperative anxiety. Language barrier I want to highlight here. We actually come across a lot of the language barrier patients here because they're more of Afghanis, Pashtun. I hope their things are better in Peshawar setup. But if you see, like, if you're talking to somebody, like if somebody is talking to me in Chinese, I have no clue. So language is very important. And this is something which is very new, the Gen Alpha thing. You must have heard it from your kids, not from yourself. But the Guardian says that the generation anxiety. So like the people are using smartphones, the smartphones, kids, Android kids, they are more prone to get anxiety and mental distress. Well, it hasn't been looked into the medical literature yet. It would be interesting. So the environment, the study says, so the place, the way they have been waiting, they familiar with that, or what kind of activities they are doing it, is it interested to this? This all contributes to their anxiety. And the study says that even waiting for more than 10 minutes in a waiting room prone them to get more anxious. Okay, so let's not forget the elephant in the room, prolonged fasting. We all see that, okay? So I have a study here from the Pediatric Anesthesia Journal, and it says multiple children reported that they experience sadness and increased anxiety when they're fasting for long period, okay? This is a review, this is not a single study. And then there's one more from the journal Anesthesiology from the nurses. This says the prolonged fasting times causes thirst, hunger, anxiety, and drowsiness. We all know that we actually say we are hangry, like because we are hungry and we are angry together. So don't expect them to be nicer when they are getting abdominal cramps and then they're thirsty. I would like to mention here, this is the guideline which has been changed from 642. We all knew that 6 for solid foods, 4 for breast milk, and 2 the formula milk. The European guidelines, which is recently published, says the clear fluids can be taken up to 1 hour before surgery. The breast milk can be up to 3 hours of surgery, and formula milk up to 4 hours of surgery. So this is very important. So there is a huge lot of evidence behind these recommendations. We can all read it and we need to read it so we can change our practices, please. This is sip to till send. This is what this is done all over the world. Like the children are allowed to drink until they are sent for the anesthetic room. This is not the ward. This is not the, and the clear fluid, I would like to highlight here, it's water, it's clear apple juice, not without the pits, without the pulp, okay? Electrolyte solutions like say, like Pedialyte and things like that. And the lemonade, ice block. If you give them an ice lolly, it would be very nice. It's a next project for us. And the time you have, like this is 3 mils per kg per hour, like this is the amount of the volume which you can easily let them have. Okay. We just need to be careful in the cases like, with their full stomach, their trauma, when you need their delayed emptying. Other than that, if you go into the detail of the fasting guidelines, they have actually give the recommendations for each and every scenarios. Okay, so and it's very clear. So now I'm coming to the interventions, what you can, so this was all like how you recognize them and how, now this is what you can do for them, okay? So there are educational approaches, there's cognitive approaches, behavioral and pharmacological. I'm not gonna go into detail on pharmacological. We all know here, we are very good at pharmacy. So, okay. So as I said earlier, when the kids, they grow up, they are all calling for explanation for everything in the house, isn't it? You are saying, oh, please, but they want to know what's happening around, okay? So they need to be educated. So research indicates that the children desire comprehensive perioperative information from you, okay? So they want to know what you want to do, gonna do with them, not the parent. Parent can transmit your information, but you need to talk to them. This is one of the booklet from Ireland, from my lovely colleague, Your Little Sleep. So the booklets, like, which is easier to read for them, which is in their language, which they can understand, okay? So these kind of things, the booklets, the video tours, the picture books, they can help it make their queries answered. You don't have to like you should be spending some time with them, but like this, that can be time consuming sometime. So you can take the help of it. Bluey, if I don't know anyone has seen, Bluey has a beautiful episode on how to behave when you are in the OR or in the doctor. This is Bablu from Pakistan, and he has been to the hospital as well. So these kind of the things, if you just give them a reference, or you can play them in your induction room, not in the induction room or in the waiting area. So rather than showing them hyperactive cartoons, you can just play like, or even a small message of it. This is difficult. Cognitive behavioral therapy. What is cognitive behavioral therapy actually? It is actually where you learn how you control your emotions, your thought, and you learn to behave sensibly. Okay. So we all go through the thoughts, we all have emotions, but this is how you want to behave. Okay. So it is this is one of the BGA journal, and it has talked a lot about the non-pharmacological options. Okay. So developing an effective using coping skills, individualizing the efforts, they regulate their emotions. It has been proven to be the most effective, more than the midazolam, okay, to deal with the preoperative anxiety. Soothing, deep breathing, exercising, tensing and relaxing muscles, like do this. Take a deep breath in and out, deep breath in and out. You see it a lot, like अंग्रेजों में देखते हैं, you see mothers talking to them. Better take a deep breath, okay? And this works. Okay, so we need to teach that, educate our parents, like the children's parents, and the children's as well, that these are the things. And others are the like distraction calming techniques, mind occupying activities, just talking to them, okay, which I find a lot difficult, because if you don't know their language, you can't tell stories to them, okay. Distraction. So this thing is very popular in packages and Emporium Mall, but it is can be popular. It is popular in the theaters as well. So there are many studies who have used the audiovisual aids to put an IV lines in the kids who have dental procedures, as this child is going to have it. And the one in the next picture is a very simple thing. We all have used it when we were young kids. Like it's just a colory thing in the hand with the maze of the pictures. So just distract them from the IV, from the needle, which you are putting in. Mind occupying activities. This is actually the puzzles. Find the volley. This is a very busy book. I have it actually if somebody wants it. And with this is a very common technique, the balloon. So the take home is that you just need to take time, okay, recognize and try to distract them, okay. Distracting techniques does work. And this is emotional awareness and cognitive thoughts. Okay, and like this, the things which I just talked, this was more on the OR settings, like when the patient is coming. This is something that our colleagues, which are not here actually, who are not here actually, that they need to recognize it. Okay, or when we see the patients in our clinic, that this is somebody who can be anxious. Okay, this is a group. The parent look anxious, the child look anxious. The child is more into the okay, you see a lot. They're not talking to you, they're not talking to you at all, they're not paying attention. So emotional awareness, okay, this is looks complicated, but just to ingrain that thing in the child that you can do it. This is not something which not everybody else has done it, okay. Opposite actions, enjoyable activity. How studies have says that if this is all pre-operative, like you have to be it has to be done mostly in our hospitals. Psychologists or pre-therapist can do it, that they just relate to a beautiful thing or a beautiful experience which has happened, or you just create that thing beforehand, okay, for them, like playing in the playroom or going to a special, or if they have been to a beautiful place before. So it is actually, you just think about it, or sometimes it is just you can create the thing. So I have seen the operating rooms or in the wards, like they have actually on the operating light area, they have the LCD on there, okay. So when the child is coming in, you can just easily distract them. It is a resource intensive, but like slowly and steadily you can move on the things. Mindfulness, thank you, Fawzia. She talked about it earlier. So it is basically the same thing, like thinking of, so mindfulness in the child, in the case of the anxious child, it's not like be present in the room. It is actually of your thoughts and the things which you have in your mind. And the other thing which it's actually the guided image therapy is kind of the same distraction therapy, and it has been well proven. It is basically the tactile sensations, sense of smell, or like the aroma therapy and things like that. Beautiful smell, beautiful texture, beautiful colors. These all help, and then you can actually teach them to reconstruct, recall those experiences if they have them, like few hours ago in the ward or in the holding bay, or if you can create some of them in your induction room. These are the few other things which can be performed, but they have not been proven significant, like music therapists, and the music therapies, well, they are very low cost and there's no harm. Like if they are not making any significant difference, they are not harming your patient, and they're not harming us either. And the hypnosis, this is very antique, actually, like I would say the very senior anesthetists, they are performing hypnosis by just talking to them. So you just need to talk. Pediatric anesthetist has to talk. Okay, parental presence. This is very important. Okay, we all know, and we think actually that the parents in the room can keep the child calm. Okay, but we really need to see that what kind of parents are they? Are they anxious? Are they calm parents? Will they help you, or will they faint on the chair? Okay, This is a child crying, not letting them go. And this can be a parent who actually start threatening in front of you that तुमने इधर बैठना है नहीं तो मैं तुम्हें बाहर जाके पैंट नहीं लगाऊंगा. So it's actually anesthetist's responsibility. Like if you think the parent is not helpful enough and the child is cognitive, like he is understanding enough, you can just bring the child in and not the parent. There is one more important thing which calls anxious. Why they have fear of surgery? Because they think you're doing something wrong to them, or they will be sore because they can gonna get a cut. So majority experience the pain, procedural pain, and it's linked to the years later. It is actually underestimated. We all think वो जैसे छोटे बच्चे neonates कि शायद इनको दर्द नहीं होता, नहीं इनको दर्द होता है. ठीक है, reducing the pain and distress related to the needle procedures. This is one of the other guidelines from European Journal. Okay, and I want to this red in thing, topical anesthetics for all. This includes IV cannulation. Okay, this includes IV cannulation, please. So we all need to make some effort. Actually, I know it cannot be possible in all those things, but we have to make some effort. This is for lumbar punctures for the same guidelines, and they strongly recommend is that you put the topical anesthetic, you use the hypnosis, and then if these things are not making up to the you're not getting to the point, they have recommended, it's strong recommendation that you have to use the deep sedation. So this is for us when we ask our colleagues to perform them in the wards. Okay. This is for the major procedures, and it still includes the topical anesthetics for the needle, the deep sedation for the major procedures, and hypnosis. We recommend the use of hypnosis for all the needle procedures. Okay, and I conclude my talk here. I'm open to the questions. Appreciate the magnitude impact of the preoperative anxiety. Don't ignore it. Recognize children at risk. Intervene. Don't starve them. Don't let them suffer in pain. This is a success story from Shaukat Khanum, and we can make it better. Thank you so much.
Thank you very much, Dr. Osman. Really an informative talk. My question is how to take IV line in a patient, in a child who is crying and is in agony with pain outside with parents, especially if you have double prick when the parents are also very panic that you have made so many pricks. So what are your techniques and what do you recommend to take IV line such patients?
So the thing is, I always ask my kids, my patients, that what do you prefer, to have a mask or IV line? Okay, so to have an IV line is a luxury, and the second thing is, do you really need an IV line? Are you doing a rapid sequence induction? If you can do a mask induction, that's another thing. Okay, and the second thing is putting AMLA on is a very practical step. So put AMLA on at least 30 to 40 minutes before you are bringing patients in for IV line. You can, like, it takes time and training. You have to talk to the nurses and put it on the multiple sites. Look at the sites where you have cannulas. You see the veins, and then put the AMLA on and tell them like this is gonna numb your skin. So these are the few things. And the next thing is, which I have shown as well, is the distraction techniques. These things look impossible, I know, but when you see people doing them, you will see that they're doing it very beautifully. So even just a talking nurse, किसी जो बातूनी बंदा है ना आपके कमरे में, उसकी ड्यूटी लगा दें बच्चे के साथ बात करना. अच्छा, अब अगर बच्चा पहले से ही रो रहा है, ठीक है, he is crying from the start, you can't calm him down. He has gone to the stress level where he's not gonna listen, he's just gonna escape. Okay, I actually send them back and pre-medicate them.
So my second question is, if you go for mask induction, and really what happens in most of the setups that 2 or 3 persons are handling badly in that child,
No.
legs and head and like that, and you
Yeah.
put a mask and you open gases like that.
So-
So he feels like suffocated, which you talked about in your presentation also. So what is the psychological impact of this phenomena in their life? Have there been any study after they grow older?
I have actually mentioned all the studies which I have mentioned. They are like like they are review articles, so they have like 300 plus. I actually want to share here a small experience. I had a child who was accompanied by his teenager, not a teenager, like 20s. So teenager wasn't allowed. So like he was in 23, her sister, and she was accompanying because parents were on holidays or something. She said, I cannot come to the anesthetic room. I was like, okay. And child was very small, like 4 years. She said, I myself had an anesthetic and I was suffocated down. Okay. So you are leaving a long lasting impact. This is horrible. Okay. What I do is that you just let them struggle. You let them struggle as long as you're not restraining it, as long as you're not holding them down. They will be happy. जैसे आप बच्चे के पीछे भाग रहे हैं, कमरे में बच्चा भागी जा रहा है, पीछे भाग रहे हैं ना, जब तक आप उसको जोर से पकड़ के यूं नहीं ना करेंगे, बच्चा माइंड नहीं करता. तो मैं एक्चुअली करती हूँ ऐसे, सब लोगों ने देखा भी है. वो बेड पे रोल हो रहा है. आई लर्न दैट टेक्निक फ्रॉम माय फेलोशिप. वो बेड पे रोल हो रहा है, आप मास्क लेके उसके पीछे ऐसे जा रहे हैं बेसिकली. This is what I'm doing when I'm not able to pre-medicate them, when I just find out that they are running away. Otherwise, pre-medicate them or intervene beforehand. But we unfortunately, when we come across right at the point in the theater.
Asma, have you ever worked in a public sector hospital?
I have actually. I have been a trainee of Sir Gangaram Hospital.
Okay.
Thank you so much. This is not from
Let me share my experience. I was like a two resident or what. There was a kid like 5 or 6 years of age, and he was brought into Jinnah Hospital Operation Theatre. And there were 3-4 people were struggling, and somebody is trying to put a mask. And our senior, he was trying to take the IV line, but we were unable to manage the kid. And then suddenly he slapped the kid. And the kid was like quite around se late gaya bilkul. They put the mask and मैंने कहा sir what have you done? कहना तैनू नहीं पता ਇਹਨੂੰ ਕਹਿੰਦੇ ਨੇ surface anesthesia. अच्छा, the second just another comment on your talk. You have just covered the pediatric component. What do you think stress and pain-free healthcare service is not essential for the adults as well?
मैंने ना जो आप you said earlier कि is this from our Ireland? नहीं. I have an opportunity to work in Gangaram, ठीक है, तो मैंने देखा है दोनों तरफ की इस चीजों को. I actually come across parents who walk into the room and child is happy looking around and parent is crying badly. और आप उसकी आंखें देखें, मास्क के पीछे सुर्ख हो रही होती हैं, आंखों में से आंसू निकल रहे होते हैं, ठीक है. So this is a complete failure of on our side that this parent has been through the appointments a lot. This child has been through the multiple appointments before they reach the OR, and nobody has recognized it. When like you can actually intervene quite early. So support groups, talking. मेरा ख्याल है बातें करना, सिर्फ एक थपकी, हालांकि वो आदमी भी होता है ना, मैं कभी माइंड नहीं करती. एक थपकी उसके कंधे पे देना और कहना कि नहीं आप फिक्र नहीं करें, सेफ हैंड में. मेरी बात सुने, हमने ना चांद पे नहीं पहुंच जाना इतनी जल्दी दौड़ के, कोई भी नहीं पहुंचा हम में से, तो खास तौर पे. तो टेक टाइम. ठीक है, मुझे पता है कि जो है जल्दी है हमें काम करने की. और योर क्वेश्चन इज वेरी रेलिवेंट. आई डू प्रैक्टिस एडल्ट एनेस्थीसिया एज वेल, एंड वी नीड टू. इट इज स्पेशली जहां हम आज जिंदगी गुजार रहे हैं, जहां हर जो इंसान है वो बहुत स्ट्रेस्ड है. वी नीड टू लुक आफ्टर ईच अदर. थैंक यू सो मच.
Any other question from we are actual short of time.
Sorry, I know we are getting late, so very important topic. You mentioned so many strategies and recipes for POR anxiety, relieving things. It is a long way and very hard work to be done. But I think you didn't touch the pre-OR sedation. Oral midazolam, intranasal dexmedetomidine. For that, we need pre-op, monitored daycare or monitor holding area. One thing, sorry. Second, again, very important about the fasting. Yes, we are listening and listening and listening and reading about these new guidelines. But practically what we are doing, and especially public sector, I think the no concept in this. What I suggest there should be, I have seen adult patients being induced after 24 hours of fasting. They are not given anything in between because they don't know when they will be induced. So I think there should be a dedicated one person monitoring the list, which should give at least this glucose drink if the induction time is longer than.
So, Dr. Tahir, that's very important point, and we have been actually doing it in Shaukat Khanum. It's been months now. We are administering juices in our in pre-op holding area, and it is like you have to just work. Thank you so much. Thank you.
Thank you very much. We are really short of time. Can we start the next topic, please?
Our next speaker is Dr. Mohammed Sohaib, an expert in anesthesia and critical care. He is the Fellowship Director of Critical Care Medicine and Assistant Professor in the Department of Anesthesiology at Aga Khan Hospital, Karachi. Today, he will be sharing his insights on the perioperative management of a septic patient.
Assalamu alaikum, everyone. First of all, thank you to the organizing committee to give an opportunity to talk. Can we open the presentation? Yeah. Okay. No, this is. So the topic given to me is like more of an academic one, not like very intellectual topics we have covered a whole day. So my talk will be on a perioperative management of a septic patient. Something will be, I will be touching a little bit of some new things. Rest will be the, like most of the people already know about the septic management we already do in our theaters. The disclaimer slide. Going to the roadmap, I will be discussing in a couple of slides the burden of sepsis, then the pathophysiology of sepsis and septic shock, what we can do in a perioperative management of a sepsis and septic shock, and in the last, the new thing which is coming up is like precision medicine in sepsis. So when I was making the presentation, I tried to look for a literature to show that how many patients with sepsis or septic shock coming to the operation theater, but I was unable to find any paper on that. So I talked to my colleagues that we need to do this study as well. So this is one of the topic I will be exploring after this, like doing this presentation. So we don't have any data, like what are the number of patients with sepsis or septic shock coming to the operation theater and what were their outcomes. So when I looked down the literature, this was one of the articles which is recently published in 2024 by one of our colleagues, which is an infectious disease consultant, and they have done a review from Pakistan that how far we have come in sepsis. And like the last study they quoted was like from Aga Khan Hospital. That was study was done in like 2013, the above one, which showed that sepsis related mortality was 37%, and like all of the admitting to the Aga Khan Hospital in 2000, like a 5-year retrospective review, the 1.3% of the admissions accounted sepsis. Then the lower down study was done by my colleague, Dr. Elias, who is a surgical ICU consultant, and that study tells us that like the more abdominal sepsis was the most frequent source, or like the source of infection, around like 57.5%, and mortality in septic surgical patients were like around 51%. In the same paper, they mentioned another paper from a Peshawar, which was also showing almost around 41% mortality. Then I searched the literature from the worldwide that what the other regions of the world. So this was one of the paper published in critical care. It is a systematic review till 2020. So they also showed that the sepsis-induced mortality, like within 30 days, was like around 34%, and 90 days was like 38%. So I was happy to see that we are not like we are not bad in managing in a septic or sepsis or septic shock mortality, almost like a 10% difference. That means like we are a low middle income country, so we can understandably claim that. So now moving on further on, sepsis definition, we all know that this sepsis this is called as a sepsis 3 definition, which comes in 2016. People are now revising it. Most probably, like in a 1 year time, there will be a new guidance. Might be we are seeing a new sepsis definition. The only thing to put this on was like sepsis is defined as a life-threatening organ dysfunction caused by a dysregulated host response, not a regulated one. So I will be like touching this in the last part of my presentation, what is called a dysregulated host response and why it's important to incorporate into this definition. So coming to the pathophysiology of sepsis and septic shock, it's like a multiple organ system involvement. First is the immune dysregulation. There is always a pro-inflammatory versus an anti-inflammatory response. And like the pro-inflammatory one, like there is always the activation of innate cell system, and then is adaptive cell system. So innate system releases the interleukins, complement cascades, and like the adaptive system includes the B cell activation and all the other things, the lymphocytes as well. The microcirculatory dysfunction, we know that leading to impaired oxygen utilization, and there is always a chance of mitochondrial dysfunction leading to lactic acidosis and aerobic metabolism. And the hemodynamic effects, we all know that there is a profound vasodilation because there is more of a nitric oxide causing profound vasodilation. There is relative hypovolemia first, and then there is capillary leakage, and then the sepsis affecting the cardiac contractility and leading to the septic cardiomyopathy. So if we come across, if we receive a call that there is a patient coming to a theater and we need to do a preoperative assessment, so we need to do a comprehensive evaluation because almost all the organ systems are involved. When I was doing my ICU training, one of my consultants said to me that like we were saying that why the platelet count are low, why this patient is having a PO2 of low, PO2 is not improving, chest X-ray is not improving, but this patient is in DIC. So the every answer to the complication was sepsis. And whenever you give a consult in a surgical ICU to any specialty, they come to the ICU, they will say, please correct the sepsis, and then the patient will become better. So we by this, we know that we need to do a comprehensive evaluation because it involves all the other systems. We have to send the laboratory and imaging through blood cultures, inflammatory markers, lactate, renal or liver function tests, and ABGs just to know the metabolic profile of the patient. In our operation theater, we usually get like, this is a data, like most of the surgical patients which come to theater are like for the peritonitis or the necrotizing fasciitis. So if we delay the treatment, this increases the mortality. So this is one of the paper which was like showing that the mortality is like 18% if there's an immediate control, and it's like if a delayed control is 43% and 100% mortality if like there is no control. And like if we delay the patient of the treatment of necrotizing fasciitis, like if the surgeon wants to control the source of a necrotizing fasciitis, getting it delayed for like more than 24 hours increases the mortality. So we cannot like refuse the patient ke pehle aap please thoda optimize kare phir dekhte hain. So we like daily see these type of patients. Now, once we are evaluating the patient, so we have like, there was a 3-hour bundle, then there was a 6-hour bundle, then there is a now is like a 1-hour bundle. So if we are assessing the patient, we need to see that at what stage of this patient is. Like if it's a patient has presented an ER, we want to see that what all the other things of like 1-hour bundle have been implemented or not, because it has decreased the mortality. But now, like recently, questions have been raised that like either every patient of suspecting having a sepsis should be following the 1-hour bundle, because from like 30 ml per kg of fluid, they go from a strong recommendation in 2016, they went to a like in 2021, a little bit of a, like a weak recommendation. Antibiotics, septic shock patient in 1 hour, but if the patient is in sepsis, we can delay to 3 hours. So still going debate on, but if the patient is coming, but as we stand now, we need to say that 1-hour bundle has been followed or not. And bundle are like a group of therapies when employed together result in a better outcome of a patient. So we need to follow that. We have to send the lactate, we have to send the cultures, we have to start the antibiotics, we have to give the fluids, and we have to start the vasopressors if the patient is not like after fluid desensitization, not maintaining a MAP of greater than 65. Now, once we are assessing the patient, we need to see the assessment of an organ dysfunction. This is important because the family will ask, what is the chances of the patient survival. So people use different scoring system. We need to incorporate some scoring system in our system just to let that what is the mortality of this patient or what will be the morbidity of the patient. So people use NESCIP score, SOFA score. We need to incorporate and we need to mention before the patient is coming to the operation theater. Hemodynamic optimization or resuscitation, because like if the patient is in a septic shock, that already has been started, and resuscitation of patient with septic shock are based on optimizing the cardiac output, like fluid administration, vasopressors, or inotropes. We all know that the patient will be hypotensive, so we'll be giving a lot of fluid, vasopressors, inotropes. Now the other thing is like early goal-directed therapy versus the usual care. It was always a debate. Rivers in 2001 proposed an early goal-directed therapy. He told us that keep CVP around 8 to 12, mixed venous greater than 70, MAP 65. So that was already goal-directed therapy, and that was incorporated in every version of a surviving sepsis campaign guidelines. But like in 2016, there was like, this is one of the meta-analysis which was published. And before that, there were like 3 large trials, ARISE, PROMISE, and PROCESS. They all said that usual care is okay. We don't need, because like, if we are doing this early goal-directed therapy, it is increasing the cost and the time, but it is not like improving the outcome. So usual care versus early goal-directed therapy is now like comparable. So usual care is the best one. Now, a couple of slides for fluids. For hemodynamic optimization, we usually use fluids. There are clearly 4 indications of fluids, that is resuscitation, maintenance, replacement, and nutrition, and we are using the resuscitation fluids. So which resuscitation fluids we can use? Like there are a couple of trials. There is always a debate, crystalloid versus colloid, crystalloid versus colloid. Till today, we say that we cannot give colloids to the patient with septic shock, but in anesthesia, if the patient is hypotensive, we can give colloids. Okay, so in septic shock, colloids are contraindicated, like starches or gelatin we use. One of the study like this is ARIS is recruiting the patient. This is the latest study which is using the albumin, and the results are not here. They are just recruiting the patient. It's a large randomized controlled trial which can give a little bit of an answer that either albumin, resuscitation with the albumin versus crystalloid like decreases the mortality or not, because this comes from the Albios trial. They have done like post hoc analysis which shows a little bit of a mortality benefit. Up till now, overall literature favors the use of crystalloids over colloids because increased safety profile and they are cheap. The main reason is that. And next big question is which crystalloid? Balanced crystalloid like ringer-lactate, which we have in Pakistan, plasma light in UK or in NHS, or a normal saline. I usually call it as an abnormal saline always, because there is nothing normal in normal saline. So like literature evidence for 0.9% saline versus balanced solutions. So like this is the last trial which like called the PULSE, which is in 2022, which showed compare the plasma light with saline, and they show that there is no difference between the renal replacement therapy or acute kidney injury. So they say that either use a saline or use this balanced crystalloid solution like ringer-lactate or plasma light, whichever is available. But clearly in the literature, like hypercholoremic metabolic acidosis and it can cause at the gastric secretion replacement, we can use saline, or in a neurosurgical patient, but otherwise balanced crystalloid solution is the answer. Now, when to give fluids? So there are like couple of, we need to check the fluid responsiveness, and we all know that there are static indicators of preload, that is CVP or pulmonary capillary wedge pressure, but we all know that dynamic indicators like stroke volume variation, pulse pressure variation, if available, so we should use that. There are new tests, there are future prospective methods to assess that. There is carotid flow time. People are using that. There is end expiratory occlusion test. They are using that, but still not in a literature very much but dynamic indicators like systolic pressure variation, stroke volume variation, or pulse pressure variation are the answer. Or if anyone is expert in doing an ultrasound, they can use this IVC collapsibility index as well. Now, in hemodynamic optimization, the second comes the vasoactive agents like norepinephrine. Still, surviving sepsis campaign said that norepinephrine is the drug of choice. vasopressin comes second. There was a large trial, Vanish trial in 2016, which clearly shows that there was no increase in the incidence of like acute kidney injury or renal replacement therapy. So norepinephrine still is the first one. Epinephrine we can use if we don't have norepinephrine, but epinephrine causes more tachyarrhythmias, more lactic acidosis. Angiotensin 2 might be like in the new coming guidelines. This was approved by FDA in 2017, and there was a large trial as well, which showed that it decreases the requirement of norepinephrine. But still, it's not a first line of drug. Let's see in next. There was an article which gives a suggestion of getting an angiotensin 2 to the surviving sepsis campaign. People who are writing that. So let's see what happens. There is also a celipressin, which is a vasopressin analog. This is yet not approved by FDA, but it was used in Europe with some study, and it also shows a promising result that it can be used as a first line drug, but still we don't have like robust studies to recommend that. Second is central versus peripheral administration. So the trial which is called as ARISE, done in 2016, we can give these vasopressors from peripheral line, just making sure that it is above the anticubital, and they have said that we can use it like for more than 6 hours if we don't have a CVP. There was an article showing that in Africa, 25% of the centers, health centers, don't have the facility of CVP. I think so. If we do it in Pakistan, so we might be coming with the same literature. So, like in an emergency, we can give from the peripheral lines. Now, the intraoperative management, like monitoring, we all know that the basic monitoring standard ASA 1-2 monitoring we need. And if we have fancy monitors like non-invasive cardiac output monitors, we can use that, arterial line, CVP, everything. It depends upon the patient condition and like the availability of resources in the operation theater. Now, we come to the physiological difficulty airway. Dr. Fatma tell that we have we need to be in a yellow line. I think so that we need to practice that, because this physiological difficulty airway we see in septic patient every now and then, and we call the physiological difficulty airway. We are all expert in anatomical difficulty airway. We see the facial features. We see that patient mouth opening is less, flexion neck flexion extension is less. But this is now the new term is coined as like a physiological airway. If the patient is hypoxemic, if the patient is hypotensive, if the patient is severe metabolic acidosis, because if we do the tracheal intubation asleep, there is always a chance of cardiac arrest, almost like it is very less, but it's like 3%. And if the cardiac arrest happens, 35 to 45% is the mortality. So these people don't come back easily. Okay. So like for hypoxemic optimization, there is pre-oxygenation. We can do it with like non-invasive positive pressure ventilation. We can use with a high flow cannula. During intubation, we can use apneic oxygenation with the standard nasal cannulas or high flow. And in refractory hypoxemia, like we have done everything, then awake intubation is the answer. The other optimization that we can use the ultrasound and anything, but like due to the reason is that refractory hypoxemia, if we induce this, all these methods are to increase the oxygen reserve, just to make that the patient is not getting an acidosis during the intubation time. The other is hypotension optimization. Vasopressors, inotrophs, we need to keep it ready during the intubation, and the induction agent, like we need to tailor it according to the hemodynamics. Point of care ultrasound may help guide period intubation resuscitation efforts and hemodynamic optimization. And the last is the metabolic. We always see these patients with the severe metabolic acidosis. What to do then? Peri-intubation, like a pre-intubation bicarbonate bolus, still debatable. People don't have an answer. But like non-invasive positive pressure ventilation and apneic oxygenation will decrease the part of that respiratory acidosis element. So they are recommended for severe metabolic acidosis, like in a physiological difficult airway to prevent the peri-intubation arrest. Moving on, further induction agents, we have like propofol, ketamine, etomidate. Propofol, the drug which we love a lot, is not a good drug for a sepsis or septic shock patient, because this patient, the propofol causes the decreased myocardial contractility in like 44% of the patient, and it also has a negative lusitropic effect, like myocardial relaxation is not there, and don't have any anti-inflammatory properties as well. Etomidate, we all know that it is a good cardiovascular stability, but adrenal suppression for like one dose can cause 24 hours, so it's not very well in sepsis or septic shock. ketamine. The ketamine is a drug which has an anti-inflammatory properties as well, and it is a sympathetomimetic, so maintains the hemodynamic stability. So whenever we ask our resident, they will come with this thread like choose the safest addiction agent, titrate to effect, and use as little as possible. So we need to monitor and titrate according to that, according to the patient situation and hemodynamics. Volatile agents, they have an immunomodulatory effect. Sevoflurane, isoflurane decreases the neutrophil activation and lymphocyte proliferation as well. And the other thing we need to remember, sepsis and septic shock decreases the MAC values, like from isoflurane from 1.4 to it's decreased to 0.8. So we can titrate with that. Analgesia, morphine, all the higher doses of analgesic drugs like morphine, they suppress the immune response. The best drug is to use remifentanil because it is not metabolized in the liver, or it is not excreted from the kidney. So it is the best drug, short acting. Unfortunately, we don't have, but like other opioids we have, we need to see the cardiac liver function and the renal function. Neuromuscular blocking agent, the recommendation is to use the benzyl isoquinoline compounds because these are metabolized by Hofmann's degradation, nothing to do with the liver dysfunction, nothing to do with the renal function. We all know that there with the sepsis or septic shock, liver involvement and renal involvement is always there. So better to use this. We can like use succinylcholine because it is also metabolized by plasma cholinesterase. So nothing to worry about in sepsis or septic shock. With the lung during intraoperative management, low tidal volume ventilation is the answer. Just like in an ICU, in a theater, we have to do a low tidal volume ventilation like 6 to 8 ml per kg predicted body weight. From the blood transfusion point of view, if we all know that sepsis induced coagulopathy, so either we do the point of care testing, and for like hemoglobin thresholds, it is like to transfuse at 7 or below 7. In a septic shock patient, around like a liver dysfunction is around like 34 to 46%. So drug selection is the important. All the drugs which are metabolized by the liver, we need to like reduce the dose or should be vigilant about that. In a renal failure, just like a last line, need to read that if somebody has done a dialysis, there is a great incidence of hypotension if the surgery is performed within the 7 hours. So if the patient has, before coming to the theater, have a dialysis, so we need to see that the patient might get like a severe hypotension on induction. So keeping in mind that. From a steroid point of view, we just don't have a mortality benefit, but it decreases the vasopressor raise and the resolution of the shock. Transition of care to the intensive care unit is very important because a good over to the ICU team will like help in getting the patient have improved outcomes. So the last 2 slides, sepsis in surgical patients, personalized medicine in the treatment of sepsis. This is called as a precision medicine in sepsis. Sepsis is always remains a graveyard for the pharmaceutical companies because they were not able to develop any drugs. But now, and on the other side, we see the oncological principles. So they have good understanding of oncological mechanism. So now the people are going the identification of sepsis endotypes because like with this, we will be like targeting the physiological and immunological things which are like specific to a specific endotypes, not treatment of septic shock fitting to all. Targeting, just 1 minute, this is the last slide. Targeted immunomodulatory therapies like targeting the specific immune response system, and like dynamic treatment strategies. Every patient is a different patient from this point of view, and we have to identify the specific endotypes to give that immunotherapy. So this is the last slide. When the facts change, I change my mind, and this is my hospital. Thank you so much for your time.
Thank you, Shoaib, for your wonderful talk covering the perioperative component of the sepsis and septic shock. I have a query. Whatever you have described in terms of management lines and equipment, gadgets, whatever, perhaps in Pakistan, only few institutions hold all these gadgets and medication, like if I talk about Khan University, Shaukat Khanum, maybe few other private, 5-star private hospitals. If you come to the public sector hospital, like if I talk about my hospital, we have a drainage area of roughly around 50 kilometers from the peripheral. This is the first hospital after the Kasur when you enter in Lahore. So most of the days we are dealing with 4 to 6, maybe at time 8 laparotomies. And these are the cases which are generally referred from the peripheral areas. Either they are not being operated, they are just conservatively managed by Hakim, quacks, doctor, and finally they are referred to the hospital, or they have been treated somewhere else, operated somewhere else, and then they are sent to these tertiary care hospitals. And perhaps this is a scenario which is occurring in all the hospitals of Lahore. The time when we receive these patients, they are already in multiple organ dysfunction. Already they are septic shock is already set in at an irreversible stage. What to do in this kind of situation?
It's like the triaging the patients. If like I will be receiving the 8 patients in an ER, so I will be identifying the patient that whom the treatment will give a benefit. If already have a, that's why I said that there are scoring systems. We need to score the patient. We need to explain the family, the mortality, the morbidity the patient will be having, like if the patient need an urgent laparotomy and everything. So I think so in this scenario, we need a good triaging. Like we need to try that which patient will gonna benefit from a surgery. If like there is I think so it's very hard to say that there is an irreversible end stage of some organ, like to explain to the surgeons that whatever we will gonna do, we will lose the patient. But like in that scenario, the scoring system little bit of a help that to convince other people that this patient, if we although we operate this patient, the mortality is like around 60%. So either we should operate that patient that carries a mortality of around like 20 or 30%.
Generally, surgeons they take on table death risk consent, so that's not an issue.
It's I think so. It's very hard to like convince surgeons, and then like if we are part of their team, then we need to tell them. And sometimes like some patients need a little bit of a resuscitation. I said that like an early surgery improves the mortality, but like sometimes we need to admit that patient in the ICU just to like this need to resuscitate first, a little bit of a hemodynamic optimizer, and then like, take the patient to the theater.
Thank you. Any questions?
Any other question?
Thank you, Dr. Soeb. I think some answers for your question is you mentioned, like say in Pakistan, in public sector, a lot of laparotomies have been to quacks and everything. Last week, Royal College of Anaesthetists has published their audit, and which they have come up, the laparotomies going to operating theaters are already 5 times later, which they should be going into. So even in the first world countries where everything is there, the laparotomies who are going are 5 times late, and 80% of them haven't received antibiotic at the right time. So it's not only an issue of a developing country or a first world country, this is an issue is still there. Having said that, one more thing is, as you mentioned, in a developing countries, where you mentioned a lot of gadgets which we have got, or hospitals in Pakistan, there's a new thing that has come up, and I'm not sure whether it's been practiced, is getting noradrenaline intravenously without even having a central line. And we have started that thing, and that's published, it's acceptable. So you can dilute noradrenaline
Yes.
while you are waiting for a central line or anything. And that could easily be done, that resuscitation in the ER or the emergency department. You should have, and you can do it. You don't need a central line to go all those things. And I think that could easily be practiced in the public hospitals as well, where you don't have facilities, you can run intravenous noradrenaline. Thank you.
Thank you very much. We are already using this NORAD through peripheral lines. I think in most of the hospitals, they are using peripheral line for NORAD.
Any
So,
questions?
If we
Thank you.
don't have any question, can you move to the next session?
Thank you, Dr. Sahib. Good afternoon, everyone, and welcome to our panel discussion. I'm honored to be moderating today, joined by an incredible group of experts in anesthesiology and critical care. I would like to invite our panelists on the stage. First, we have Dr. Fauzia Mir, a consultant anesthetist at St. George's Hospital in London. She has deep expertise in difficult airway management anesthesia for the airway surgery. Dr. Mir has led major airway conferences, including DAS 2017 and 20, and currently serves as a DAS treasurer and ASM lead. Her work has been instrumental in shaping airway management practices globally. Next, we're joined by Dr. Asad Latif, Chair of the Department of Anesthesiology at Aga Khan University, Karachi, trained in the US and board certified in anesthesiology and critical care medicine. Dr. Latif focuses his research on patient safety, quality improvement, and health system strengthening in developing countries. Also with us, Dr. Khalid Samad, an associate professor at Aga Khan University and Hospital with specialized interest in cardiac anesthesia. Dr. Samad's expertise in this area has been invaluable in advancing our understanding and practice of cardiac anesthetic care. Then we have Dr. Ehtesham Khan, who has built an esteemed career in anesthesia and critical care with fellowships from both Pakistan and Ireland. He has held influential roles, including Vice President of the College of Anesthesiology of Ireland and Chair of its Credentialing Committee. He has been an examiner for over a decade across Europe and Caribbean. Dr. Khan currently serves as Chair of Anesthesia, exemplifying leadership and dedication to advancing patient care and medical education. So our discussion today addresses a critical issue, which is the brain drain of anesthetists from Pakistan. And the recent statistics reveal an alarming number of doctors, especially anesthetists, having left the country over the past few years. I'd like to invite our esteemed speakers to share their insights. Dr. Fawzia, would you like to start off?
I would like to say this is not a Pakistan problem. It's a problem in UK as well. Quite a few of the people that I know of personally, as well as professionally, they've left UK as well. So it's not just Pakistan. And I think the title is very, very telling. Greener pastures, grass is always greener on the other side. So there are issues, there are problems in every country that you work. And I don't think there's anything specific to pinpoint and say, this is why you left for another country and therefore you got the brain drain here and not there. It's the same, and we just need to work around the working conditions that we have. So it's not just us alone here.
So speaking, let's talk about Pakistan. So let's discuss whether this trend is largely driven by political, economical, and social factors, including limited resources, challenging work conditions, or better opportunities abroad. Would somebody like to add on this?
Hello? Yes. Thank you. So it's a interesting question, and one that, as Dr. Fatma said, everybody's struggling with around the world, right? And I've been on both sides of the equation. You have to look at what the real reasons for brain drain or anybody moving is, and it boils down to three basic reasons. Either financial, valuation, the environment in which you work, and family, right? So the incentives for anybody to take a job are basically those three things: that they like the work that they're doing, the money is great, or their family reasons. And this is, if you look at it, the reasons why people leave, also the reason why people come back. And I think that population of repatriates is probably who you learn this most from. Usually you need at least two of these three to move to a new location. And these days, it seems like money holds greater value. But I think the population of repatriates are the ones that need to be looked at to see what it is that brings them back. And usually in Pakistan, people who go abroad, number one is family. And that's why that group of repatriates is a time-limited group who come back after their training's finished, come back for their parents, and once their parents have moved, once the situation is resolved, they often go back to wherever they came from. So what is it about the ones that stay that makes it better, right? So either its financial compensation is improved to a point over time where they stay, and we have many examples of this in the fine city of Lahore, in Islamabad, and Karachi, or it's because they find value in the work that they're doing. So I think there's only not much we can do about family, not much we can do about money. Money is never enough, depending on where you are. There's always somebody who makes more and more that you want to make, but at least you want to make sure that there's adequate financial resources. The area where we can really work is creating an attractive environment for people to work where you are. This comes down to many things, whether it's work culture, opportunities for growth. And this is not just financial growth. This is growth in academics and other things, in things that they're interested in. We've developed programs in which people can, one of the reasons Khan attracts people is probably not the financial. I know people in private practice make more money. It's often because the work environment is better. I've heard quotes from other people saying, oh, hum apni betiyon ko bhejte hain Khan ke andar. They feel safer, so they're willing to take a lesser salary. Unfortunately, we do capitalize on that. Then there's things like opportunities for growth in areas that might not be possible. So like Dr. Khalid, some of this about environmental conservation and doing research in that. We started a program in doing research for that. So making that enabling work environment where you can explore your interests, right? My own reason for coming back was not really financial, definitely not financial, was in my family. But definitely the opportunity to make a difference. And I think that we can work on, whether it's a public sector, whether it's a private sector, or in our academic institutions, that is something that we can probably capitalize and optimize further.
I would like to add in this a little bit more. By moving abroad, what you can get is a higher level of qualification. And these days, a very attractive point is to get another passport. So if you move to Ireland, UK, or some other country, USA, whatever, and any other country, so you can get a passport, which is a big edge. Now coming to the basics, what is the problem? Why the brain is drained? You trained a person for like 4 years, and he started his qualification from the MBBS, then he does part 1 or whatever qualification he's trying to achieve. Then he does an intermediate module, he writes a thesis, he gets his fellowship done. And the day his training is complete, he has been thrown out of the public sector hospital. A person who is now almost capable to become a senior registrar is just thrown out of the system. Now, at present, we have 168 medical colleges. And out of these, almost 130 or 140 are private hospitals. So they get a better chance of getting a faculty position. Straight away, they are either selected as a senior registrar or as an assistant professor. So they start getting chunk of the private practice from those hospitals. They have got a recognition as well. So that is one of the factors. The other thing is, if you know exactly, we don't have a data how many qualified people are present at this particular time. According to PMDC data, it is somewhere around 4,000. They are qualified. 33% of them have higher qualifications like major diplomas, and 66% of them have minor diplomas. Then your peripheral areas, they are becoming better. They have better working environment. They are getting better wages and better private practice. So many of the people who are working in the major cities, they have they're like moving towards the peripheral area. So that is the reason you don't have enough of the number. And another very important component is that if I talk about the public sector hospitals, in comparison to one PGR who is selected for the anesthesia residency, there are almost 20 PGRs who are selected in the relative surgical disciplines. So there's a lot of discrepancy in the number of the inductions. People don't opt anesthesia as a career. We don't have curriculum. We don't have lectures in the final year, 4th year. So once you go to the students, you just interact with them. You tell them what you are doing, the workshops, the other something which they get attracted. We don't have anything to attract them. They don't have rotation in the wards. At times they come to the OR, at times they don't. So these are few factors which lead to the movement of these. Thank you.
Can I say something? The most reason what I suggest for the brain drain is lack of jobs in our setup. And secondly, as Dr. was saying that at this stage, maybe he was pointing towards Professor Jodha that he has enough money at this time. But most of our junior anesthesiologists, they are striving hard for bread and butter of their kitchen. It's honestly. So when you complete your residency, one of your junior medical officer who is doing private practice, and you gain fellowship diploma, which is the biggest diploma in Pakistan, I think, and very well recognized abroad also. There is no difference in payment in between that medical officer and that fellow. Rather, that medical officer may be getting more practice because the surgeon will assume that fellow may charge a bit more than that medical officer. This is one reason. Secondly, they may have new horizon to while going abroad for studies, but I don't think they have less resources in Pakistan. If we have very good teaching centers in Pakistan also, it may be one reason, but majority of them are moving abroad due to lack of jobs, due to not scoring of jobs over here. And if I talk about my specialty in my hospital, people are really overstressed because we are really having short of manpower daily on daily basis, and surgeons are not compromising on their surgeries, and hospital is our administration is enforcing that please anesthetize the patient at any cost. Sometime we come across the situation where we don't have an ICU bed, and one of the very senior bureaucrat or something like chief minister house calls, please accommodate this patient in ICU. We say there is no bed in ICU. Please put an extra bed, which are पाई ला के इसको लिटाएं कहीं पे ICU पे. So they don't try to understand. Our government, I think, must consider it very seriously that these people who are moving abroad, they are the asset of Pakistan. They should not move like this. Thank you.
Dr. Ihtisham, would you like to add something considering you've worked both in Pakistan and in Ireland?
Can you hear me? Okay, it's working. Thank you, Sana. I think when this green pastures thing came up, I felt bad because in the last 10, 15 years, I think more than 70, 60, 70 anesthetists, I've been responsible to move out from this country. But I was feeling bad. But then I realized, I think there are a lot of good things has happened. We should not be looking brain drain as a problem, but it's a good thing. The country, which is my second home now, Ireland, is a big immigrant country. Since the famine in the 1800s, a lot of Irish moved all over the world, and America, England, Australia. And the country was smart enough, I would like to say that, the country who was a very, very poor country and is now one of the richest in the world. And now what they have done, and the reason for one of them is the diaspora of Irish people all over the world, they use them and they are helping their own country now. Even the Irish people who have been in America or England or Australia for 100 years, 150 years, their family, but they still come back and they are still helping the Irish people. So the same thing from Pakistan, people who have gone abroad, settled there, they are an asset, and they are helping back in Pakistan in various ways, not only monetary, but what we should do is to have a diaspora, and what Indians have also done it recently in the last decade or so. The diaspora in America, England, and other Western countries, they are using that diaspora to help back home in India as well. So I think we should do that, have visiting faculties coming in here, setting up those things. And I think that's the way we should get benefit. And I think doctors going abroad, some of them come back, bring their experience. And at the end of the day, it's really working out very nicely for Pakistan.
I started my training in 1998 and I did my residency from Khan Hospital. And when I applied for anesthesia, only 2 people applied for the residency. Last year, we have 60 candidates for the residency program. So the number are increasing. But to me, people are looking for better opportunity. They need to understand that there are hospitals in public sector and the government sector that offer the opportunity they can provide. People are not smart. They know where they're going and what they will get. So even after doing a residency, one thing is to attract the people toward the residency program in anesthesia. And the second one thing is to provide better opportunity after the residency. Because when we were trained, there were no fellowship programs. we did our residency, and then the next day we were the consultant after giving the experience. Now competition is increasing. There are fellowship programs, and we try to induct people who have specialty training in a specific program. So now residents who train from a specific program, they are smart and they are looking for the opportunity to open up their options, not only in Pakistan, but also abroad. So we need to understand that we need to provide some kind of additional qualification after the residency program where they can train and then they have the opportunity to open up their options. It's not about the passport. It's about having the better opportunity, not in Pakistan, but all over the world.
Can I also add one sentence to that? So, speaking from a personal perspective, when I was a medical student here in Pakistan, I honestly didn't even realize that there was an anesthetist in the operating theater. They were that invisible. And we got 1 week of rotation in the operating theater. And of course, all of us were interested in more seeing what the surgeon was doing, not what the anesthetist was doing. And I think that's something we really need to work on. We have brought the image of the subspecialty. We've got to work on it. We've brought it down. We must take pride in it so that it's more glorified, and people are attracted to do anesthetic fellowships and training. I only realized how important anesthetics was when I went to UK and I started my training there. And there is no comparison between the impression given here in Pakistan to anesthetics and abroad. And that's one reason why there aren't enough a workforce or enough trainees which are being attracted to do anesthetics in future. So I really think we need to work on that as the first thing. And secondly, we need to make the working conditions better for people to return back to Pakistan. So after you've done your training, and I know a few people from our neighboring countries who did all their training and then went back to their home country because they think their quality of life and their raising of the children and everything was much better in their home countries. So we must provide that incentive to our trainees who go abroad so that they can bring the expertise back to the country, and then we can have better future for anesthetics here.
Would anyone from the audience like to add something?
Yes, multiple factors. To go out, yes, as our worthy speakers, they just mentioned, yes, financial reason is there. And then to improve the qualification, the weightage of qualification. Yes, with our qualification, you can go to the Middle East, but not beyond that. With Western qualification, you can move around the world. You bring expertise. Yes, this is the factor. But at certain point after that, many people, they want to come back. Like in India, they give them attraction with better working conditions. So a lot of them, I know, even my friends, they went back. I know many Pakistani, my friends, they want to come back. We planned many years back, yes, let's go back. So I just give you one example. There are so many things, not only the working conditions. Yes, when they come back, what they will do professionally. But more than that is the law and order and geopolitical situation. I tell you honestly, I had been through this. So even one incident with one of the colleagues regarding law and order, that discourages a lot to all others. My children, they were just very young, 4 years, 5 years. We were on holidays in Lahore, and we had a robbery at home. One fine morning, 5 gentlemen came in the house with guns. So that trauma, still my daughter, then she did not visit Pakistan for 10 years. So this political and security situation, this is also very important, which, you know, is a hurdle.
So what do you think is the solution of all of this if we want to stop this brain drain, as Dr. Tahir has said? So what should we do? What I think we should, what can we do is to just to make some request to authorities which are least concerned about these our problems.
Yeah,
What
it
may
should be
your
brought up
working
to the
condition.
national level. You know, one is the working condition. Yes, they want something to, for financially, they need something and better working condition. Aga Khan is providing, Shaukat Khanum is providing, so few private sectors, but they are a little bit, you know, some closed spaces and not enough. They cannot accommodate everyone. But with these dialogues, we have to bring it up to national media and with our government officials. Yeah, if you want to bring them back, yeah, first thing is, do you have a will to bring them back? We are happy that our people are going abroad and bringing some, Zare Mubadala is coming to Pakistan and we have foreign reserves. This is the thought process of our government. You take them on the board. If they have a will, yes, we need these expert people to bring them back. Yes, provide some better situation, improve law and order.
Recently,
to
I
my-
visited one hospital in UK and I was surprised. I thought that the hospital is closed, but I was told that it's a routine. Nobody will be outside. There will be no crowd, no parking, no vehicles like that. So if you compare those hospitals with our setup, where you are even unable to pass through that crowd, being you are being consultant or doctor, so the condition, working condition is totally different. If you talk about that, your education of the children, this is one point you have just mentioned, that was robbery, and it's increasing day by day. Education of your children, your health facility, so everything, if you look around, all these lead to that brain drain.
To my opinion, unless government play a pivotal role, like it has to be taken as a challenge. I recall that in 2010 or 11, the Ireland, they were lacking anesthesia personnel. They relax all their rules. Even I knew few people whose IELTS was even, they just forgo it and then just induct those people. So being president of PSL Lahore, I have been to health minister, the previous secretary, additional secretary, and the special secretary. I have been to all of them with all the proposals and the challenges which we are facing. If I just talk about my hospital, we have 43 operating tables. And would you imagine how we are running that? We are running, we have only 39 PGRs. What quality would you expect me to deliver? Government think that we have given you enough resources. You should give us a quality equivalent to UK. When it comes to resources, human resource and other thing, we don't have anything to cater our people.
So as just to follow up on that point, and that Dr. Khalid made as well. So a decade ago, so me and a lot of people, we were going abroad to improve our sort of academic standing, get some degrees, come back. But I think the alarming thing now is that a lot of postgraduate residents, they are leaving as well. So what we're looking at is maybe if we know we don't have a problem in recruiting at the moment, like Dr. Khalid said, but if we are faced with a situation where, let's say, somewhere, anywhere in the world, it's UK or Ireland right now, or some other country decides to give better economic and lifestyle packages to people who have just graduated from medical school, then I think this will become a problem for all of us. So just my comment.
It's very interesting to listen to all of you. I have been to the both parts as well. So one thing which I want to just say is the world is moving towards the globalization. Okay. So everybody's moving. As Dr. Sham said, like the people from Ireland, they have like the doctors itself, and from the NHS, they move to the UK, they move to like from Ireland to moving to UK, or they're moving to Australia and US and States for the better life. So I personally don't think it's a brain drain. The second thing, because they are bringing the expertise back as well. as in the form of when they come back and work, in the form of the visiting faculties, in the form of when you people are coming here and teaching our trainees and giving us your perspective. The second thing, which you all have mentioned as well, that we need to create more opportunities for the people who are qualified. Okay, so like when I qualified, like it's not long time ago. It's not long time ago. It's recent. So there wasn't any job for me. So I had to go and look for a job in a private setup, which was like 1.5 hour drive from my home. And he was paying for like back in 2012, 1 lakh rupees. Maybe it was a lot at that time, but it was like trainee was earning 90,000. He was offering me 1 lakh. So what I am saying is that, yes, you have to create the opportunities. Everybody has a right to look for a better opportunity for them. And the second thing is induct more. As Dr. Jodat had said, like the government should be looking at the things like we can only run the services we have when we have enough manpower. And I actually want to share one small thing here. I don't know the statistics of that actually. We all know Mahathir Mohamad, Malaysian's ex-prime minister. So Dr. Estesham would agree. There are loads of Malaysian doctors coming to Ireland every year. They are in the medical colleges, thousands of them, and the Malaysian government is providing them scholarship to read, to study there, and not all of them go back. And one of the ministers or like advisory board, they came up to Mahathir Mohamad and they said like they're not coming back, like, and they said, and why are you worried? And they said like, if they don't come back, what will we get? He said, so because they were being sent on the scholarship, they said, okay, if they're not coming back, they can return the money. Okay, that's one good thing. You invested the money, you're getting the money back. And the second is produce more. So I think so Pakistan, India, and China, we are very overpopulated actually. You see Chinese in every corner of the world. You see Indians every corner of the world. I don't think so India is worried about the brain drain. We Pakistanis are. Well, we need to produce more. And we are producing more actually. Thank you so much.
Well, you would think with 168 or however much the number was of medical colleges in Pakistan, we should be producing enough. So I don't know where the missing link is, because 168 colleges for a country like Pakistan is a good
Probably
number.
they're going into pathology and dermatology and psychiatry. So that's what, like, it was, you all have already talked about it. Like, so we need to like attract our specialty. If we think that more people need to come into the anesthesia, we need to induct more. We need to like have more anesthetic seats for us.
Yeah.
So we need to like invest and intervene at multiple points.
No, that bit I strongly agree with. We need to popularize our subspecialty. We need to work on that, because as far as I remember, anesthesia was the only specialty when I graduated, which people were keen to join, because you could get a rotation or a training post within bigger cities if you work for free. Now, that working for free business never happens in UK. Nobody works for free. And in fact, anesthetics is so popular there that people actually, there are 10 people queuing up for one job at any time. So there is something wrong we're doing there. If it's
ये एक लतीफा भी मैं मेरे से सुन लें. When I went to my house job interview in Fatma Jinnah, okay, so I opt for anesthesia as a house job, okay, और मेरा जो panel वहाँ बैठा होता उन्होंने कहा अभी सर्जरी में सीट्स हैं तो आप एनेस्थीसिया में क्यों हाउस जॉब ले रही हैं, आप सर्जरी में लें. मैंने कहा नहीं, मुझे एनेस्थीसिया करना है तो इसलिए मैं एनेस्थीसिया में. So this is like kind of the mentality, and this is all we have to deal with it. Thank you so much. Huh? Why I was okay. So I did my first house job in medicine, and I saw the people dying every day. And I saw my senior colleagues not doing anything. And then I saw when everybody is dying or we need something, we are calling an anesthetist to intervene. So I was like, ye koi hai jo ke kuch kar sakte hain. So I want to be one of them.
I would like to take this opportunity to actually involve some junior doctors to give their insight or their thoughts about working locally versus working abroad.
Ma'am, I just have a question for the previous discussion that we had. I'm a resident doctor in anesthesia department of the anesthesia department of the Shaukat Khanum, and I just have this one question that we young doctors, we are actually the strata of this population that are leaving this country, and the dilemma is our councils they are not doing as much as they could have done for our basic rights, because the doctors here in Pakistan are not as much safe as they have to be. There are no as such legislations for their protection. We have seen many incidents all over the Pakistan where the doctors have been bullied, they have been beaten up, they have been even they were killed due to some incidents, and yet the council, those who are taking care of us, and the senior panels like you guys are here, what you guys are doing for us so that we should not leave this country and stay here, even though the finances, yeah, everybody cares about that, but that is not as much we need. We need practice, we need something to learn, but more of that, the safety or our basic rights should be considered as first choice. Thank you so much, sir.
Yeah. Go ahead.
You bring up some interesting points, and this is actually going to go into my query of others. Bad news always travels fast, right? And there's always sensationalism around this. It would be interesting to see whether violence against doctors versus violence against other subgroups is actually higher, or is it just a perception? This is not a big thing in most of the graduates in Karachi, but maybe in some public sector hospitals, and this does get sensationalized. You're right. Safety and security is an issue. Somebody else brought it up, but the people, I was at Johns Hopkins for 17 years. Every day, there was at least 2 violent crimes happening for physicians or healthcare workers around campus because somebody would mug them. It was just that part of town, right? That didn't discourage people from coming to Johns Hopkins. So we talk about resources, we talk about seats and stuff, but we have to, and a lot of social commentary, but I think we need to step away from that because in some ways, akin to what Dr. Fatma is saying, the specialty has moved towards learned helplessness. Overall, Pakistanis have, but also in the specialty, to some extent, we do have a self-image sort of issue, and we need to work on that to move towards the fact what we can do. And I think we need to move the conversation towards that. One of the questions is, you talk about recent graduates. We don't have defined career pathways. Dr. Khalid is alluding to this, but we don't actually talk about it regularly, right? We put out, last year, we put out our largest graduating class because we went from 5-year to 4-year program and we put out 28 people. And, suddenly putting out 28 people in the market, we felt, what do we do with them? And speaking to them, turns out they actually didn't have any career counseling. And there's no defined career pathways or where they should apply. All our graduates apply from every program to the same places. They see what they know, but there's no defined career pathway. When I graduated from the US, I knew that I could apply to these 20 programs or these 120 programs around the country. These are the hospitals. These are the ways to apply. But there's nothing like that. There's no institutional coordination for this, no intra-city coordination for this. And for some reason, nobody in Karachi applies for a job in Lahore other than Shaukat Khanum because we're not aware of any jobs. And I actually think this is a failing of us as a specialty, and this is the failing of our leadership. Associations like the PSA, for example, I'm sorry, sir, but we don't have defined career counseling or career pathways. We have no specific job portal across the country to know where we will get jobs. And this lack of opportunities, people knowing what to do, I was shocked. I actually had a career counseling session with my residents, and they're like, sir, and between 24 of them coming from all parts of the country, they could only name 5 places where they thought their jobs existed in Pakistan. They knew of nothing else. And coming to that, they're like, okay, I think this input hamara bada, output, as we increase input, we do need to define outputs and where people go, and you'd be surprised. So when we did this, we actually got 4 people who went to Akhan sites in Gilgit. Never happened before. And now certain people are willing to go there because, oh, we don't know there's a job opportunity there. We didn't know they're going to pay more. We didn't know that we could do that. Shaukat Khanum is often a place that goes, and we have some collaboration. If somebody applies from us, they call us, but we don't actually have references. We don't pick up the phone to call for our graduates to get jobs in places, and we don't actually tell them where to go. We actually need to focus on that a lot more because this brain drain is not necessarily a bad thing, but I suspect a lot of people this is what they learn, right? I went to Akhan as a medical student, and I had no intention to go to the US initially. Udhar dekha, sab ja rahe hain, to main bhi chala jaunga. I'm sure many of us learn from our immediate circles. We need to expand our immediate circles to the entire country. And I actually asked the PSA to help do that.
Let me come to your question first. Did you ever heard this kind of misconduct, beating and whatever you were telling about with the young doctors in any CMH hospital, anywhere in Pakistan in CMH. Have you ever heard about it? No. Have you ever heard about it in Shaukat Khanum, Aga Khan University, Shifa International, Ittifaq Hospital, etc.?
Maybe
No.
they have they already tapered the news. I can
So
expect this.
here's the answer to your question. The public sector hospital, the government didn't have any intention to improve the working condition.
Yeah.
डॉक्टर साहबा ने गंगाराम में काम किया, इनसे पूछे इनका ड्यूटी रूम कैसा था? Did they have attached bath, which is a basic necessity? बहुत गंदा था। वही मतलब आपका बेसिक ह्यूमन राइट है, हमने टॉयलेट तो जाना है ना, हमें सैर बंदे ने जाना है दिन में 2-3 दफा। अच्छा, now coming to the, because the government has no policy for this type of bullshit. You have seen multiple cases. YDA comes into play, they rescue the people, they rescue the doctors, and perhaps this is the right way of doing things. When somebody is beating you madly, this is the only solution. And later on, negotiation done with the health department, and the YDA plays some role, they get some benefit, and this is something which is going on for the last one or two decades. Now coming to Sir Asad's question, we have a clear pathway in Punjab. I'm not sure about Sindh. There is a system which is called as Punjab Residency Program. Whosoever either clear the part 1 for the fellowship exam or MS examination system, they are inducted by the Punjab Residency Program all over Punjab. So as a supervisor, I don't have a choice to select him or him, depending upon their credentials. So we are bound to have those people. Now, next is once they leave, as I was telling you, the person who is about to become a senior registrar is just jobless. So because they don't offer a seat of medical officer, they don't offer a seat of some kind of instructor, senior registrar, or any other position. And we are stuck with that unless government is going to announce the post even on ad hoc basis. Nobody can induct these people into a public sector hospital. And you know that the major chunk of the healthcare is still provided by the public sector hospitals. The private hospitals or the autonomous body institutions, they are catering a limited number of the cases. Like if you talk about Shaukat Khanum, where you are working, you're not taking an emergency, you're not taking any obstetric load, you're not taking any walk-in emergencies. So you are doing almost an elective kind of procedure. If I talk about Lahore General Hospital, we are catering a load of almost 40,000 surgeries per year. We have 2 ICUs, 42 operating tables, and I've told you the situation. I'm stuck here. Being PSA president, I have been to all the possible forums where I can go, but nobody is there to listen. Dr. Ashraf Sayah was with me, and the last secretary they called. They just kind of develop a paper where they increase the number of the seats for the SRs, APs, and associate. We also requested them to create seat for the pain medicine. We also requested them to create seat for these intensivists. But all the paperwork has been done. When it has gone to finance department, they have just hold the file. So every possible outcome of these students who are just trained, we don't have anything to offer them. Unfortunately, we are tied by the health department.
I think one thing to add on to these things, every country has got their own problems and old solutions. When I was looking into this bottle, for this plastic bottle, what it says, इस्तेमाल के बाद बोतल में छेद करके जाया कर दें. Because the problem is we are reusing these bottles, so it's a problem. But in countries like Europe, we don't छेद करके, we don't zaya, we use it for recycling. So every country has got their own issues. And I think one more thing, you will say I'm living abroad, so that's why I'm talking about. But this issue of facilities and what government is doing is everywhere. We always are looking for our rights, but we never talk about our duties. And I think that's one thing. But still, there is a lot. It's happening good in this country. And one thing you mentioned about the medical council, it's not doing. I think it's good your medical council is still ignorant, because if you look into the medical council in Ireland, we are really screwed and we are already always on our edge. One thing goes wrong and you are up onto the medical council and your license is cancelled. In Pakistan, you know what's happening. You can even go and get away with the murder as well. So sometimes it's good in a society where the medical council is not as good and looking after you. Otherwise, it would have been very bad.
So, as said by someone in the audience, a brain drain will be there, but we need to concentrate on the production. So I don't know what kind of production we are talking about, but okay, okay.
So one question, production to hai, but like we all are a part of a CPSP, like we have done actually. We are like CPSP ने खुद अपना प्रोग्राम रखा है कि 2 साल के बाद आप चले जाएंगे, and we have allowed that. अब तो हमारे पास रेजिडेंट इसीलिए शॉर्ट है, जैसे सर कह रहे हैं 43 थिएटर्स हैं, 39 पीजीआर्स हैं, मेरे पास पीजीआर्स नहीं है, एंड पीजीआर्स लाइक पोस्ट ग्रेजुएट रेजिडेंट्स आर लिविंग इन बिटवीन द ट्रेनिंग. So we have created that loophole ourselves. Yes, after completing the residency, once they are not getting the job, they can go. But like in our residency program, they are leaving and they are going for a better opportunity to the Ireland. So what thoughts about that? Like we are all part of a CPSP.
CPSP is getting some chunk for every resident which is sent abroad. So they're not going to stop that.
This is the answer for us.
I think the number of seats are fixed. It's like per year 2, 3, 4, 5. It's not more. But if people are opting for the Ireland jobs after completing their exam.
I think so. Dr. Ehtisham can answer this question. I don't know because he knows he was part of that council. Like,
say it again.
The CPSP, like we are producing like PGRs in an anesthesia, but like CPSP is allowing them to leave the residency here in Pakistan. They can go to Ireland. Like so, we are producing PGRs, but somebody said that Dr. Joseph said that CPS getting a little bit of a chunk of money from them, then they are providing the manpower to run their hospital.
No, I would say CPSP is really doing a good job, and we always blame. But to be honest, if you look into, they are sending it for 2 years, but they have to come back. They cannot stay there. Their registration stops, even if somebody wants. So I think it's a blessing. It's go. Not every hospital is like Shaukat Khanum or Aga Khan, where the doctors haven't seen facilities. So it's good. CPSP is sending them, and those doctors are coming back, and they are getting those experience, what they say. So I think in that aspect, I would say CPSP is doing an excellent job, and you don't blame CPSP on that. But most of the doctors come back and stay here.
I would like to add one thing. From our own setup, we 22 PGRs have fled for Ireland after completion of their intermediate module, and none of them is back to Pakistan. I have that data with.
So if I talk about CPSP being Dean of Anesthesia faculty, when CPSP sent these PGRs abroad, they have a surety bond with that they will definitely come after 2 years. And as Dr. Sabha said, if they don't come back after that time, their license is cancelled, and they have to come back, have to pay if they don't come back. So CPSC, I agree, is doing a wonderful job. They send abroad, and then those residents were trained are bound to come back after 2 years.
I apologize.
Jodat's question, the 22 hasn't come back. I think, Dr. Jodat, what they do come back, and they may go into some other areas. And you are in one way right. Sometimes they come back for a year or 2 years, and then they again go back to Ireland. That is what we are seeing. But a lot of them do stay. I think if CPSP every year, because I take interviews for them, 15, 16 come, I think most of them do go back to Pakistan.
हमारे PGR की बड़ी जबरदस्त टेक्निक है. Just before leaving, they get married. One of them they did जो जाता है वो 2 साल की जॉब करता है. By that time, their partner start job and they stay there for a year, and then they are eligible to work again. So that's how Call Associate is managing their manpower in Ireland.
डॉक्टर जोधत, ऋषि सुनक के साथ आप थोड़ी सी मीटिंग रखें. उसके पास बहुत सारे आइडियाज हैं इमिग्रेशन को रोकने के.
So I'm sorry. We're a little short on time, so I apologize for cutting this discussion short. I would like to thank the audience and the panelists for such a dynamic conversation, discussion. Thank you very much.